Marc-Olivier, can you start and give us your scientific analysis and your gut feeling about preload responsiveness indices in clinical practice, please?
Thank you very much, Bernard. So, is there a magic tool for giving or stopping freeze? 20 years ago, Frédéric Michard described the PPV as the pulse pressure variation. This dynamic index corresponded to an interaction between heart and cardiac and pulmonary interaction. And the pulse pressure variation could be used for intubated, ventilated, in mechanically ventilation patients without spontaneous breathing, in sinus rhythm, and having an arterial line. In this proof of concept study, Frédéric Michard described that PPV has an excellent predictive value for the fluid responsiveness. 10 years after, Laurent Müller showed that finally this dynamic indices is not able to predict fluid responsiveness in the real life. But why? The difference between the two studies are, in fact, that we actually used more lower tidal volume. And finally, a lot of situations could change the cutoff value of PPV. In fact, when we used low tidal volume or low pulmonary compliance for our patients, the PPV value was decreased. In contrast with the right ventricular dysfunction or the intra-abdominal hypertension, we can increase the PPV value upper 13%. So how to do in practice with these dynamic indices? In fact, perhaps we can delete these confounding factors using hemodynamic maneuver. How to do that? At first, we can predict fluid responsiveness using PPV changes induced by hemodynamic maneuvers as a mini fluid challenge. For example, you can use a mini fluid challenge with 100 milliliters during 1 minute, and if PPV decreases more than 2 in absolute value, you can perform an fluid loading. The second situation could be the recruitment maneuver. If PPV increases more than 13%, you can perform an fluid loading. And finally, if the tidal volume challenge from 6 to 8 milliliter per kilogram increase the PPV value more than 3, so you can perform a fluid challenge. The second step is, in fact, only when the first was okay for fluid loading. You can assess the hemodynamic response to the fluid using PPV changes induced by fluid loading. 3 cases are possible. The first one is PPV decrease after fluid loading, probably because cardiac output increase, and you can perform another hemodynamic maneuver. The second situation is PPV was unchanged after fluid, so no efficacy of the fluid loading, you can stop the fluid. The last one is PPV increase after fluid loading. So be careful because there is perhaps a right ventricular dysfunction and you need to stop the fluid and perform an echocardiography. In conclusion, fluid therapy is a major key of postoperative morbidity, and the hemodynamic challenge should be preferred to the fluid challenge, not only to predict fluid responsiveness, but also to assess hemodynamic response to the fluid. Thank you.
Thank you very much, Marc-Olivier. So these dynamic indices in real life, are they always usable or are there some limits?
Effectively, there is a lot of limitation for this dynamic indices. In fact, 20% of patients could be have this monitoring in the operating room, because we need 3 conditions to use this device. At first, the patient should be in sinusal rhythm. Secondly, we should use mechanical ventilation without spontaneous breathing. And third, we need an arterial line. For this last point, if you used the PVI, this is a non-invasive device, you can perhaps upper the proportion of patients having monitoring with dynamic endesis. But in fact, there is few patients in operating room who can benefit of this dynamic endesis.
So indeed, that's a very small proportion of patients. And if we have to predict, that means giving even a small amount of fluid might be very dangerous for that patient. Is it always true that these dynamic indices can avoid giving unnecessary fluids to patients that are at very high risk of being endangered if we give them these fluids? Are there some specific conditions in which the dynamic indices might be, in fact, might be induce a wrong decision from the anesthesiologist?
We can perhaps use this dynamic endesis not only alone, but also with a multi-parametric approach. Perhaps can we use also the cardiac output monitoring using perhaps the passive leg raising or the recruitment maneuver, and if the stroke volume variation or the stroke volume decrease more than or increase more than 10%, perhaps we can perform a free challenge.
Okay, yeah, I'm glad you mentioned the passive leg raising maneuver, because this is another completely reversible, non-invasive maneuver that allows us to test the reactivity of the system, avoiding giving probably unnecessary fluids in the patients that are the most at high risk. In fact, is there any strong evidence today that using these indices can really improve outcome in patients, or are we still waiting for stronger data to comfort this opinion?
It's difficult to respond to this question, Bernard, because finally, few studies are performed to answer at the clinical benefit for the patient. And no large or wide study are performed with a randomized design to answer to this question. And so at yet, we cannot actually recommend to use at bedside every day for all patients this dynamic endesis, or finally, we can perhaps conclude that this dynamic could help in a strategy or a peri-operative strategy, but probably more securely with a multi-parameter approach.
Thank you. Didier, you have a comment?
We have time perhaps for a short question to you. Thanks a lot for this overview, quick overview, which is challenging for you and for everybody here. So first of all, for the passive leg rising, since you are becoming more and more hypovolemic, we suspect the hypovolemia concerns also the legs. Then the amount of fluid you can mobilize in the passive leg rising is negligible or smaller, at least, when you are severely hypovolemic compared to the patients who are not. What is for you the reality, the validity of this test to know that we have to give fluid? That's the first question. The second one, just to know, we give fluid and you see, we look at the stroke volume as recommended nicely, and then the flow. Do you think it's important for testing the stroke volume and the cardiac function, or it's important for testing the global cardiovascular system response to the fluid loading? What else?
Thank you, Didier, for this question. In fact, a multi-approach is very interesting in this context. And we should look at the central venous pressure variation induced by the passive leg raising. If the CVP increase more than 2 millimeter of mercury, we can say that the venous return is accurate for an increase in stroke volume if the patient is stroke volume dependent.
Maybe Didier, to reinforce your view, it is assumed that passive leg raising will be responsible for the mobilization of 200 plus or minus 50 milliliter of fluids, but in fact, nobody knows what is the exact volume of fluid that will be mobilized by the test. Yeah. So we don't know. We don't know. I don't know if you agree with that, but the passive leg raising test, it can be useful, but in fact, we don't know if the hypovolemic status of the patient will influence, of course, the positivity or no of the maneuver.
One thing is clear is that if you are wearing contention stockings, you reduce the capacitance of these superficial veins, and certainly the volume of blood that is mobilized under these circumstances is probably less. So that's the limit of this test, certainly. But we don't need to have a lot of volume to be mobilized to test the system, because normally the first milliliters have the greatest effects on flow. So even if we mobilize 100 mL, if there is no response, we should be concerned that the patient probably is not fluid responsive.
Fully support this.
Yeah.
That's a good point. I mean, if we have something which is able to tell you very rapidly, even after a few cc's coming centrally to the heart cavities or something like that, and then you see that the flow does not change, maybe even after 50 mL, it's sufficient. Because I measured in the legs, the amount of blood is less than 80 mL in healthy people. When you move this, you move 40 cc's per legs, which means 80 cc's globally in normal people. Then your hypovolemic could be less. But I agree with you, the first cc's are the most efficient for the cardiac output and the stroke volume increase. So if you don't have this, I agree, this is an alarm to be very careful. Something happens, the heart maybe doesn't work well. I don't know, something happens, and then maybe we have to stop rapidly the fluid loading.
And maybe one point that we should emphasize before we switch to the next presentation is that these tests and these indices are not telling us that the patient requires fluid. They just tell us that the patient is able to respond to fluid. We still have to decide clinically whether or not our patient needs fluids. I think this is an important issue.